Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maximum Eleanor Blum Patient Family Learning Center at Mass General. Today's program is a part of a special collaboration between the Blum Center and the Mass General Hospital Heart Center. Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for it in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to today's guest speaker. Joining us today, we have Dr. Colleen Harrington. Dr. Harrington is a cardiologist and faculty member at Mass General. She is one of the Associate Program Directors of the MGH Cardiology Fellowship and the Cardiology Clerkship Director for Harvard Medical School. She is the current governor of the Massachusetts chapter of the American College of Cardiology and serves on several of their national committees, such as the Cardiovascular Disease in Women Committee, as well as the Cardio-Obstetrics Work Group. Her clinical and research interests include heart disease in women and valvular heart disease. She joins us today to give a talk on menopause and heart health. So please join me in welcoming Dr. Harrington.
Amy, thank you so much. It's just always such an honor to be invited to these sessions. It's so critically important that we educate our community about heart risk. As you know, heart disease in women is a special place in my heart. We've clearly underestimated the risk associated with pregnancy, which is another area of interest, and patients I see, as well as my clinical research, as well as the menopause transition, which is much more significant than the medical world gave credit for. And so it's wonderful that we're getting these educational webinars, clinical research, so that we understand this transition for women, better address the needs of our female patients, and move the needle forward in heart health. A lot to cover. And so my topic, as you know, is menopause and the heart. Is there a connection? Well, now, yes, there is a connection, which is why we're talking about it. I'm going to try to not use medical terms as much as possible. And I really want this to be more of a conversation. I put the data up there so you see where the things that I'm saying, the facts that I'm saying, where they're coming from. But really, I'm going, and certainly look at the slides, but I'm going to be really giving an overview for most of the slides. So in order to give you the most information about heart risk, heart health, and the menopause transition. So thank you again. These are my consulting fees. My consulting other responsibilities and positions that I have. There's no relevancy to what I'm talking about today with those opportunities I've had for consulting. So the outline of my talk, I'm going to briefly talk about menopause, the different stages of menopause. We're going to discuss the timing of menopause, which many of us really cannot control, but what that effect on cardiovascular health with regard to the timing of menopause. Really going to spend a lot of time on highlighting menopause characteristics relevant to when we say cardiovascular risk, we're talking about heart risk. We're going to also talk about cardiometabolic health changes associated with the menopause transition. I'm going to present the Women's Life Simple 7 at midlife to talk about ways to minimize your risk. Now, the therapy for many of the things that I'm talking about is way beyond the scope of the hour that I have here. I'm briefly going to talk about that. And as Amy said, these are great questions to bring to your medical team. So let's just start out with cardiovascular disease in general. I'm a cardiologist, so though I see, and my passion is heart disease in women, I see men and as well. And just to take a big overview, cardiovascular is the leading cause of death in females. This is more than other cancers combined, and I have a graph here showing that. However, despite great seminars and educational webinars that we have here, that awareness, for reasons we're really not sure, actually is going down. And then a couple of surveys, as mentioned here, have actually shown that only 56% of females, when polled, actually put cardiovascular disease as a #1 cause of death. Well, great. What is cardiovascular disease? So what I'm going to concentrate mostly is on coronary artery disease. And that's a fancy word for plaque buildup in the heart arteries. The heart arteries are the coronary arteries, and those are the ones when they become significantly blocked, that's what causes a heart attack. So the heart, as I tell my patients, pumps blood to the whole body, but the heart needs blood in order for it to do its job. And it's those coronary arteries that actually supply the heart muscle with blood so it can function. So when I'm saying the word coronary artery disease, we're talking primarily about stenosis, is a fancy word for narrowing of those heart arteries. We'll talk a little bit about heart failure. What is that? It's when the heart is not able to keep up with the needs of the body, whether it's a pumping issue, it can't squeeze, or the way that it fills. And so that's a fancy word for heart failure. Heart failure doesn't mean that the heart's going to fail tomorrow. It just means that it's not able to keep up with what that host person, patient needs it to do, running, going upstairs, etc. So just an overview. And, this was published in 2017, really demonstrating the magnitude of heart disease in women. 400,000 women died in 2016 from heart disease. Now, again, this is all heart disease, coronary disease, heart failure, and so this is sort of a broad spectrum of heart disease in women. At that point, less than half of the women polled recognized that heart disease was the #1 killer of women. Actually, a quarter of them found it embarrassing to talk about it because they felt that everything was related to weight, and they felt like potentially their medical team would blame them, which is, very hard to hear that. But the reality is the reality. Only less than half actually had their routine care or their annual physical brought up the fact that heart disease was the #1 cause of death in women, and what can I do to reduce that risk? Also, the medical community, we're responsible for this as well. This has not become, or not a top priority for some primary care physicians. And even in the next walking across the slide, even cardiologists felt that they were not prepared to assess cardiovascular disease risk in women. This is broader this is broader implications than even what we're going to talk about today, and ways that we have to improve the education of our trainees, making it a comfortable conversation with our patients so that they feel they can tell us these things that they're concerned about, and making sure that we feel comfortable guiding them in their heart health and how to reduce their risk. And the awareness of this actually does differ by age. And so, meaning the awareness of heart disease as being a #1 killer in women. So on the left screen by age, younger women were less likely to be aware of this. So the bar graphs are the percentage of unaware that heart disease was the #1 killer of US women. Those with lower socioeconomic status, so under 50,000 annual income per year. If they, and now moving across your slide, if they had some college or less, they had a higher percentage of unawareness when related to those who had completed college or then some. And we're seeing differences by ethnicity, with Hispanic and African American women less aware of the heart disease risk in women. What is this? Yes, this is not easy to hear. It just looks, we have more to do. We have more work to do. So now let's talk about women and the menopause transition. So females develop coronary heart disease. Remember that narrowing of the heart arteries years later than men, with a significant risk during the menopause transition. Do you see how I'm not calling it menopause all the time? Because I'm going to show you graphs. The transition happens way before and continues after you have your last menstrual period. We have more and more data that this is not in women's heads, that there is difference in their body fat distribution. I've seen pretty big changes in their cholesterol with no other factors really changing in that patient's life, and the cholesterol panel being significantly worse as they go through the menopause transition. That's the blood test that your doctors and your advanced practice practitioners are checking. And these findings really accelerate. We now recognize that the menopause transition is really a time of accelerating cardiovascular risk. And okay, great. That sounds very depressing, Colleen. But again, more education to pinpoint these risk factors so we reduce our risk. So I look at this as opportunity for engagement and opportunity for intervention. So again, it's not a moment in transition. It's a multidisciplinary transition that occurs during midlife. And there's actually 3 stages. It's perimenopause, which is the most symptomatic years. We're going to talk about some of those symptoms. This is the key time, and I would argue premenopause, is a key time to reduce cardiovascular risk factors. I check cholesterol panels in my patients who are in their 20s, if they've not had it done. So, but in particular, we know that risk increases, particularly during this transition time of menopause. Really key time to intervene. Know your numbers. What's your risk? The definition of menopause is you've not had a period for 12 months, and then we have the post-menopause period that can be, again, as I've mentioned, almost 50% of some women's life, they're in the post-menopause stage. So it's a transition from reproductive to non-reproductive phase. Significant changes in hormones, as I'll show you next. The median age in the US is about 50 years. No, there's different types. So it's natural if it happens naturally, but some women, for many medical reasons, have to have their ovaries removed. And that puts them immediately into menopause. And that's no transition at all for them, which can be quite dramatic and very, very tough to go through. And so again, some definitions. Premature if it happens prior to 40 years old. Early menopause if it happens 40 to 45, with the average, again, about 50. So as I mentioned, with the life expectancy of 81 years old of women in the United States, many of us are going to spend a fair amount of our lives in the postmenopausal stage. And so it's important to reduce your risk as much as you can before you hit menopause or menopause transition, but continuing that trend when you are in the postmenopausal stage. I only put this up because this is a lot. This is the stages of reproductive aging. From the time when you're early, when you first have your period, is -5. And then there's 5 stages, variable, and when you stop having your period. So this is much, much more than I think society, even the medical society, really gives credit for what the stages of reproductive aging is in women. With about 5, give or take, of stages, and all of the top part of this arrow is the different hormones that are changing, increasing, decreasing estradiol, follicle stimulating hormone. I'm not going to get into the weeds of medical terms, but what I'm saying is there's a lot of changes happening all the time, but particularly through that menopause transition. And this is just a graph to show that point. Then your top right is levels of estradiol, with that midline dark black graph as a number of years around. That's the final menstrual period. Do you see way before that woman experiences their last menstrual period, how much fluctuations is changing in that estradiol or estrogen, which is the female reproductive hormone? And then on your bottom right is your follicle stimulating hormone, which stimulates follicles in order for you to produce eggs that are, if you desire to have children, that is how, we get pregnant, is those follicles develop into eggs and then they get fertilized by sperm. And so you can again see how much the follicle stimulating hormone on your bottom right is starting to increase way before the woman experiences their last menstrual period. So let's talk about menopause related symptoms. Why? Because later in this talk, I'm going to tell you everything I list is somehow related to cardiovascular risk. Okay, menopause doesn't cause heart disease, okay? But the risks that are associated and the symptoms associated with menopause seem to be associated with cardiovascular disease. Again, a fancy word for heart disease. So many of us, if we're on the call, have been through perimenopause, menopause. There'll be, you can relate to some of the symptoms that women can experience during this time. Again, way before their last menstrual period. Hot flashes and night sweats. In some studies, almost 80% of women will experience that. Depression, anxiety. Another one that's not listed here is a brain fog. I hear this all the time in my patients. They can't sleep, not only because of vasomotor, which is a fancy word for hot flashes, they just have different patterns in their sleep, in addition to genital urinary and sexual function changes. And all of these things can really affect a woman's quality of life, as you can see. And the timing and the frequency of these vasomotor symptoms, again, hot flashes, night sweats, can vary over time. And we know that women that have vasomotor symptoms will have increased risk of cardiac or heart disease. To no fault of that patient, we just see that association. And there are therapies, again, I'm not going to go into it. There's new medications on the market that can help women if lifestyle modifications for these symptoms simply do not work. It's really multifactorial. We do know that women who have hot flashes and night sweats may have higher weights or body mass index or obesity before menopause. Cigarette smoking, higher levels of anxiety and depression may be linked to more of an increased risk of having night sweats and hot flashes. Data on exercise, diet, alcohol is really inconsistent with its effect on having increased risk of vasomotor, again, hot flashes, night sweats for women. Anxiety and depression. We know anxiety and depression are linked to a higher heart risk overall for men and women. A lot of these things that I'm saying apply to my male patients as well. So, but we do see an uptick in anxiety and depression in women going through the menopause transition. It seems to decline in that post-menopause period. And please know there's always individual variation. As I mentioned earlier, the increased sleep complaints is real, and it's not all due to sleep apnea. Almost 15% of females in some studies have had poor sleep, which we know is an important part of heart health. You know, getting that 7 to 8 hours of sleep is really important. And when women are waking up, not only from hot flashes, but only a change in their sleep patterns, they're not rested. They're going about their day already, you know, having a tough time, whether they're balancing work, life, family, taking care of parents. You can see how this can also lead to anxiety, depression, and all the other things, sedentary behavior, and perhaps obesity. Does the age of natural menopause matter? I mean, there's some things we'll talk about today we can control, some things we can't, but the point is to get the education out so that you do understand that it does matter. It seems that earlier menopause, again, happening naturally, this is not surgical where someone we put into menopause. It may be linked, you know, if you have menopause later in life, it might be sort of a marker of overall health. And the aging of your body. I know these are not fun things to talk about, but it is unfortunately what it is, and understanding that more, I think, is important. Meaning, if you have natural menopause later in life, it seems to be associated with longer life expectancy, higher bone density, lower risk of fractures, reducing death and overall death and cardiovascular death. However, maybe some link to breast and ovarian cancer. That is not a strong association. Are there factors that influence the timing of natural menopause? Yes, and some we might be able to control. No, this is a really evolving area, and some we cannot control. So women that tend to have shorter cycle lengths, meaning the time that you have your period every 30 days, every 25 days, if your average cycle length is shorter, it seems that you might reach menopause a little bit earlier. If you've never been pregnant, you might hit menopause earlier. If you've had your first period before 11 years old, which is considered a little bit early, seems to be an association with more likely to go into menopause earlier. And certainly if you've not had a pregnancy at any point in your life. Contraceptive use is really not conclusive on whether or not it affects the timing of menopause. The data between race and ethnicity, there's some signals in the literature. I'll just say overall, it seems to be inconsistent. So people will ask me this, and I'll just say there might be, we might see Hispanic, Native Hawaiian, and Black females may experience menopause younger, but please know there's a lot of studies that don't show that association. More work to come to kind of understanding these racial and ethnicity differences in the timing of menopause. Interestingly, it doesn't seem to be strongly linked to diet, exercise, or alcohol with regard to the time of your natural menopause. So again, I'm educating, but there's not a lot to do in the fact of what you can do. Some of these are just characteristics that we're seeing. I get this question all the time. What about my mother had menopause at this age? I have to say clinically, I tend to see it very similar, but when you look at the studies, it says it's really much more complex than that. That the age of menopause may be linked to DNA patterns, maybe accelerated aging of the cardiovascular system, meaning that whole heart, brain, circulatory system might be associated with early menopause. So again, more to come, more studies that we clearly need to understand this. The Tobacco Association, so that is something that you can control in every talk that I ever give from, a child of parents who both smoked and not judging at all. The best thing that you can do, menopause aside from this or not, if you're on the call or listening later on and you smoke, the biggest thing that you can do to reduce your risk in anything is to stop smoking. Is it easy? No. But please, if anybody is there and listening, and you are, the biggest thing you can do right now to reduce your heart risk and also risk of stroke is stopping smoking. And it seems that women who smoke, and this is over 200,000 patients, that those women who smoke seem to have menopause earlier than those women who never smoked. What about the cardiovascular, health prior to menopause? And I think this is when we're going to then talk about some heart risk where we can try to reduce, monitoring blood pressure and cholesterol, and we'll get into that a little bit later. So we're very lucky to have the Framingham Heart Study that has really given us this longitudinal, meaning we're following patients for a long period of time and understanding who's developing heart disease and who's not. And so the Framingham Heart Study showed that higher total cholesterol and blood pressure before menopause were associated with earlier menopause. These things can be controlled. So knowing your numbers, I'm going to say that a lot. What's my blood pressure? What's my cholesterol? And if you don't know, it's important to know. And controlling those things. It doesn't mean medications all the time. It could indicate lifestyle modifications, but that is a controllable risk factor for early menopause. Women, almost 200,000 patients, if they had a heart event, meaning a heart attack, before the age of 35, they seem to be at risk for earlier menopause. Sorry, this froze there for a second. How about menopause characteristics relevant to cardiovascular risk? Okay. So the age of natural menopause, we've talked about this, which is why I've sort of gone into this segment next. And so age at natural menopause before 45 years of age seem to have a higher risk of overall and fatal heart disease. And those women with early menopause, less than 45 years old, had a greater risk of heart failure. And so this is a nice graph showing in red, those women less than 45 years old with the incidence of heart failure on your y-axis and age by your x-axis. Those women in red, less than 45 years old, who had early menopause, had a greater risk of heart failure. And as I alluded to already, it does seem to matter that women, for other reasons that are very important, need to take their ovaries out, which is where our source of estrogen is, in addition to some other areas, but primarily the ovaries, it does seem to matter. Now, that doesn't mean that if you need this surgical menopause, there's ways of hormone replacement therapy that you should talk to your providers about. I have a few slides on HRT or hormone replacement therapy, but definitely more of a conversation if you're putting a woman into menopause surgically. So it seems if this surgery, which is usually a hysterectomy with taking your ovaries out, and it's a hysterectomy with a bilateral salpin oophorectomy, which basically means you're taking the ovaries out. If it happens around the time of what we consider natural menopause, again, the median age about 50, there doesn't seem to be a risk of heart disease later on from the data that we have. However, when that surgery happens, younger in the 40s or before 40, there seems to be a risk of taking those ovaries out, which you need to with heart disease later. Again, heart attacks, in particular, what we're talking about, and potentially heart failure. And this is work from one of my colleagues at MGH. I work with such amazing colleagues at the Women's Heart Health Program, showing surgical menopause in this orange-yellow color, showing those women who had surgical menopause had a higher risk of high blood pressure, high cholesterol, and diabetes. So what does that mean? We just have to really, really monitor those patients and be aggressive about their risk factors so that we can modify that risk in any way that we possibly can. And we can, and make a huge impact. Okay, so what else about the menopause stages with cardiometabolic and cardiovascular risk? And so blood pressure tends to rise later in the menopause transition. As I said earlier, the cholesterol changes not in the way that we want. The total cholesterol, which is TC, HDL cholesterol, which we're going to talk about in a second, LDL cholesterol, triglycerides, they tend to rise. HDL is considered the good cholesterol. I'm going to tell you something, it does change. Its role changes in menopause. It's not as good. LDL cholesterol is low density cholesterol, which is the most associated with plaque buildup in the arteries, not only in the heart, but in the entire body. And we even have studies now to show that these arteries in our neck, if you ever feel your pulse when you're exercising, that the thickness of that neck artery called the carotid artery actually does get thicker with menopause and menopause transition. I know this all sounds very depressing, but these are things that we can monitor if your team needs to monitor. If you have high cholesterol, treat that with diet and exercise and medications if indicated. We do have interventions to treat these things that we're seeing with the menopause transition. As I said earlier, depression is associated with higher risks of coronary artery calcification. So what is coronary artery calcification? So this is a nice slide. This is a calcium score, examples of a calcium score of 0 up to a calcium score of 1200. You or your family, or maybe you've had one, a calcium score is a CAT scan that just does a very quick view or image of those heart arteries. Remember, the coronary arteries. And when plaque or cholesterol plaque gets, it starts to deposit in these heart arteries, they become calcified. They don't all get calcified, but most of them do. Medicine is never straightforward. That calcium is what we're seeing. And then the overall volume of that calcium puts out a calcium score. Okay. And so depression and anxiety seem to, in some studies, link to potentially having a higher calcium score. And it seems to be associated with the higher risk of cardiovascular death. So all the things that I said happened during the transition, not for every woman. We see the vasomotor symptoms, depression, anxiety, poor sleep, overall do affect a woman and a man's heart health, in the fact that depression seems to be linked to high risk of cardiovascular death. And vasomotor symptoms seem to be related. So a woman who has vasomotor symptoms, we tend to see cholesterol levels more abnormal. Insulin resistance means the effect of your body's and its response to insulin, which really sucks the glucose out of, or the sugar out of your blood into tissues. That's the word that you hear in all magazines and things like that, insulin resistance. It means the glucose is hanging around in the blood where it should be, not all of it, but should be pushed into the cells, because that's what our cells use in order to produce energy. So insulin resistance seemed to be linked, hypertension. Again, this thickness of these neck arteries called the carotid arteries. These things are not in women's heads. These things, we have objective cardiometabolic changes that happen during the transition of menopause. So the metabolic syndrome is also, we tend to see it in women who don't sleep as well. That could be multifactorial. You don't sleep, you don't have as much energy, you may not be exercising, which is one of the ways of decreasing the chance of getting the metabolic syndrome. So the metabolic syndrome is lower levels of that HDL, or good cholesterol, elevated sugars, which we do not want, high blood pressure, which we do not want. Abdominal obesity is a real thing, and increases your risk of heart disease, and high triglycerides. These are another component of that cholesterol panel that your medical team might check. And so we alluded to some of these, but let's go in. And I'll just point out, a lot of this is repetition. It's important to drive this home, is that these changes that we're seeing just don't seem to be linked to age alone, in that the menopause transition seems to be associated with changes in the cholesterol panel, not in a favorable way. And also the HDL, which is what they call the scavenger. It's the cholesterol that, runs around the blood system and sucks the cholesterol and brings it back to the liver to process it. So it's a good thing. However, we now know that higher HDL levels after menopause may not be as beneficial. I'll tell you, the world of lipid and heart disease is exploding. And so I think we need more data with regard to the role of this good cholesterol in the post-menopause state. It doesn't seem to be as beneficial when compared to women in the premenopausal state. And so, again, the metabolic syndrome, I defined that a few slides ago. It increases with menopause. And again, over and over again, this is not just what we can blame on aging alone. This is the transition that a woman is going through during a very important part of her life. And it seems to be different, more pronounced, the risk of metabolic syndrome with menopause in Black females when compared to white. And again, a little picture of this. Again, I keep going to the carotid artery. Again, if you feel your pulse, if you're exercising, and some people like to, well, now everybody has fancy watches, so they're getting that data from there. But this thickness, in those heart arteries, or sorry, the neck arteries, we can see that on ultrasound, and it seems to be associated with menopause, and also the stiffness of the vessels. So these are real cardiovascular changes. And what I mean by stiffness, it means, as you feel your pulse, you can feel a pulsatile. It's a beautiful pulsatile thing. The walls become, as I tell my patients, almost not like a lead pipe, but that's a good image, is that it just is not as contracting and expanding the way that it did when the patient was much younger. And that we see that with menopause. And then definitely we see, for sure, visceral changes. And so what does that mean? It means fat distribution does change and increases with menopause. And it's really doubles and really accelerates around the time of the final menstrual period. And is this in our heads? No, because in research studies, we can take these beautiful pictures, and sorry, this got a little bit cut off, of the yellow and the pink fat. The yellow is the subcutaneous, so right underneath the skin, but we actually see abdominal fat around the organs, and that seems to be accelerated during the menopause transition. I'll tell you, I don't order these abdominal fat MRIs. This was done for research, but it does show those changes. So menopause, again, does not cause cardiovascular disease, but we experience many changes in our bodies that can impact our heart health. This is a nice little summary of the things that we just discussed and how they can be linked to cardiovascular or heart disease. So what's about, this is the Go Red for Women on the American Heart Association, the Women's Cardiovascular Health and Life Simple 7 at midlife. And I would argue, if you're not midlife listening, this should be started as part of, way when you're still menstruating and way before you're even premenopausal, okay? Know your numbers. What's your BMI? That's body mass index, okay? That, although there is some criticism that not one size fits all, it gives you some benchmark of what your weight is, and there's BMI calculators all over the web. You punch in your height and your weight, and it will give you, your overall BMI. We know that waist circumference makes a difference, and so in postmenopausal women, if their BMI is greater than or equal to 40, and over 30 as a reference is considered obese, and their waist circumference is over 115 centimeters, there's an increased risk of heart disease later on in life. And those ones with a higher central obesity, so more in the center of your abdominal obesity, higher risk of death. And so, again, sounds all very depressing, but know your numbers. And if you're not in that, talk to your, in what we would consider normal, which again has some variation. What are ways that you and your medical team can talk about getting you down to a lower BMI? And if you are considered overweight, over 25 BMI or over 30 is considered obese. People ask me this all the time. Physical activity is so, so important. I would not counsel my patients if I didn't do it myself, because I just don't think I would be able to do that. And so 150 minutes per week, I know that's a lot, but there is, I can tell you study over study over study shows the benefits of physical activity. Walking is a simple, except weather permitting. I tell all my patients, as I trained at Hopkins in Baltimore, up here in New England, the winter can last for months and months. You need a plan B for inside, because what happens is people fall off these great, great habits because they don't want to go out in the snow and the ice. And I completely get that. But that physical activity has to be continuous. It has to be, maintained throughout the year, minus an illness or some kind of injury. And unfortunately, we don't see that most women in midlife are really hitting these benchmarks that the American Heart Association recommends, greater than or equal to 150 minutes per week of moderate intensity aerobic activity, or 75 minutes per week. Aerobic I always tell my patients some light weights in order to make sure that they're maintaining their muscle mass is important, except if you have certain conditions. Again, the importance of discussing with your health team. I really like this from the World Health Organization of building this limit sedentary time. And yeah, I don't say patients go out 5 days a week now if you haven't been doing anything, because for multiple reasons. You want to really, increase that slowly over time. Start with 1 day, and then increase to 2 days is how I advise my patients. So again, I don't, I can't emphasize this enough, how the importance of smoking cessation is so important. And I would say the other thing that I haven't highlighted yet to this point, all of these risk factors, the cigarette smoking, the hypertension, diabetes, the risk of causing heart disease is higher in women than men. There is definitely sex differences. I did a talk last year on the sex differences. The impact is real. So it means that all of us women here, we have to do more to reduce our risk, unfortunately. But we can, but it seems to impact us more. And cigarette smoking, absolutely, as much as you can. There is counseling, there are medications you can use. It is utmost importance to decrease your risk of heart attack, stroke, and overall death. Diet, I get asked this question all the time. We could spend half the day to a day on talking about this. As I'm sure your parents told you, eating more fruits and vegetables is always the way to go. Plant-based fats and oils, or we have data, they're less associated with that that fat around the organs, as I mentioned, and I showed the picture of your abdomen. These sweet snacks, we see higher fat distribution in the liver, which is not a positive thing to have. Some things that research studies have shown is this health eating index. I put it up here for reference as a guide of how much saturated fat, total fat, fruits, vegetables, meat, dairy. I always say try to take the lower fat dairy. The Mediterranean diet is always an excellent resource. It's what's sponsored by the American Heart Association, and you're tried and true for maintaining heart health. Know your numbers. It is so important to know your cholesterol numbers because that is something you can target, and decreasing your intake of saturated fat, increasing your physical activity, and losing weight can get these numbers down. It doesn't mean everything I'm talking about means that you're going to get a prescription for it. I mean, that's a conversation to have with your team. And yes, medications can be very effective, but diet and exercise go a long way too. And there the numbers are there. They're very poor. Unfortunately, we're not really hitting anywhere near what we should be for controlling cholesterol. So among females over the age of 20, greater than or equal to 20, having an LDL cholesterol greater than 130, 1/3 had that, even as young as 20, which is why I do check cholesterol panels on my younger patients, because if I can start prevention then, I can really make an impact when that female patient is 65. Know that there is some variation between ethnic and racial groups, but in general, your total cholesterol should be less than 200. Your LDL cholesterol should be less than 100, and triglycerides should be less than 150. Now, if you've had a heart attack or stroke, those numbers are going to be, or those goals will be less. Know your blood pressure. Again, know your numbers. Okay, this is up here for your reference of what's considered hypertension, what's normal. In general, less than 130/80 is what I ask most of my patients, with most of us knowing 120/80. That's a great blood pressure. And we know that hypertension, not only is it modifiable, but it increases the risk of having high blood pressure or hypertension increases as women get older. Particularly women over the age of 6 years old. However, those in the 40s and above will have higher risks of hypertension, even more so than men. And most patients do not know their blood pressure, and even just checking that is one area that you can start to know your heart health, know your numbers. Diabetes. So overall, diabetes is increasing for male and females, likely linked to the obesity crisis that we're seeing and physical activity or inactivity. However, the risk again is higher in women with regard to becoming a diabetic and how that affects your heart health. I have a little reference here about what normal glucose or sugar levels are in general, less than 100 if you're fasting. There is a blood test called a hemoglobin A1C, which is a 3-month marker and gives you a percentage of your overall glucose or sugar levels. If your doctors feel that would increase the knowledge of your heart risk, then that's a blood test that can help. It doesn't mean you absolutely have to have it, but knowing your glucose at least is an important part of whether or not you are diabetic or not. And again, a stronger risk factor for women when compared to men. So, okay, we're running a little bit out of time. And so I talked to you about those 7 ways of knowing your heart risk. Know your numbers, know your blood pressure. What is your BMI? What is your cholesterol? Am I diabetic? Am I hitting that physical activities? And if not, how can I do that? And how can I improve that in my life? Lifestyle modifications are so important. It's a cornerstone of every visit that I have with my patients. Things that we didn't talk about today, but I talked about last year is, diet, exercise, stress reduction, mild mindfulness, yoga, meditation. All of those things are so important, in our overall heart health. Getting adequate sleep. I know that can be challenging with work, families, whatever else is going in our lives. And then if lifestyle modifications or your physician and APP or advanced practice practitioners feel that you need medications, besides the things that we can't control, some with the age of menopause, a lot of the things that can affect not only the timing of your menopause and then your health after menopause. These all things listed here can be tackled. Hypertension can be treated, high cholesterol, diabetes, obesity, and again, I can't say it enough, tobacco cessation. Now, the elephant in the room about HRT or hormonal replacement therapy. We have full day seminars on this. Know that the data is very, very inconsistent. And there was very much in the favor in the 80s and the 90s, fell out of favor. And so the overall summary, because I feel like this would probably be on a number of you of your minds as you're listening to me talk, it is not recommended to prevent heart disease. Primary or secondary, meaning your first cardiac event. Secondary is I've had an event and I want to reduce my heart event or stroke event. Any woman, if you're listening, again, talk to your providers. If you have a high risk of cardiovascular disease, it's not recommended. It really can help with the vasomotor, genital, urinary, and bone density properties. And you do not want to have really any of those contraindications. From the data that we have, it seems to be more effective if it started closer to the time of when you hit your last menstrual period or really hit that menopause of 12 months of not having menses or your periods. And it seems less than 10 years in total of therapy. Again, some variations. Any patient with a history of a heart attack, stroke, blood clots, pulmonary embolism is blood clots in the lungs, blood clots in the legs. If you've had breast cancer, those would be considered general contraindications, meaning hormone replacement therapy would be high risk for you. I really like this. This is one of my fellows actually at MGH. She published this as the red, yellow, green light for those patients, high risk, avoid menopause replacement therapy, caution, and then low risk. I put this much up there for a reference. I have patients come to me, and then as a team, we decide, is this what the risk is for that patient? So this is very, very individual. These are just broad things that I can tell you from research and guidelines of what's recommended, and know that there's a lot of individual variation. I really encourage you to talk to your team about what's right for you if this is something that you're considering. So take menopause to the heart. Women are at a greater risk for heart disease and stroke after menopause, making it more important, so more important to focus on your health before menopause and throughout the menopause transition. This is the American Heart Association Go Red as a little summary slide of what we talked about. So menopause and heart health. Menopause is not, I wake up and I don't have my periods anymore. I hope I've shown you it's a big transition that happens years before you even start to see a change in your menstrual cycle. Perimenopause by far is the most symptomatic years, but that can be variable as well. And then, as I mentioned, many of us will spend almost 40% of our lifetime in that postmenopausal period. And I would say, if you are listening in your postmenopause, it's not too late. Any of those things that we talked about is applicable to every phase, and even when someone is 20 years old. There's always improvements that we can do in our heart health. And so, keep that in mind as we talk about the ways to reduce your risk. As I mentioned, menopause does not cause heart disease, but all of these changes can increase our risk of heart disease. The decline in estrogen, hot flashes, night sweats, depression, sleep problems, increased fat around the body organs, increased cholesterol levels, increased blood pressure, and that's stiffening of those vessels. So take menopause to the heart. I hope I've shown you the importance. I cannot stress how important it is to get active. It doesn't have to be these, gym classes. Walking is the simplest thing that you can do, and easy for most of us to do. And if not, talk to your doctors about other alternatives. For some patients, a stationary bike works better for them. As long as I'm getting them moving, I know that I'm reducing their heart risk. eat healthy. I would use the American Heart Association website is a phenomenal resource for heart disease in men and women, heart disease in women, the menopause transition, diet. They even have recipes. They have ideas for mindfulness. I mean, it is a wealth of information, data-based information to improve your heart health. And then finally, I hope I've stressed, know your numbers. That's knowledge is power. We all know that. It's so important to know your blood pressure, your body mass index, your cholesterol, blood sugar. It really does add the value to the conversation that you have with your medical team to talk about your individual risk and what you can do today and moving forward to reduce your heart risk for having a heart attack and a stroke. And so with that, I believe that's my last slide. Really has just been an honor for me to speak with you for the last hour. I hope I've drove home some of the important points of heart health for women, not only during the menopause transition, but throughout their entire lifetime. So thanks, Amy. I'll hand it off to you. I think you have some questions and I'm happy to answer them.
Thank you, Dr. Harrington. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. You had referenced Life's Simple 7. Where can one go to learn more about it?
Right. The Go Red for Women AHA website will have many of these Life Simple 7 and other ways of reducing your risk. We'll have a lot of the things that I talked about the recommendations for exercise. It gives you ideas for different exercises. And so I would go to, www.aha.com or .org, I can't recall. They will have so much information for all of you that you will click into one and then click into another. Next thing you know, it's 30 minutes and you've been on a website and you've learned so much. And the importance of it'll also show you the data behind this, which I think is always important. Where are they getting these recommendations? Where's the studies? Some of my patients really want to know that, and that these are not just sort of expert opinions, but this is actually data-based recommendations that really can make an impact of reducing not only heart disease and stroke, but actually reduces death. I mean, it's really so powerful. I think there was.
Thank you.
There's
a question about the differences when it comes to hormone replacement therapy versus bioidentical hormone use.
Yes, and I would say, just because of the timing, there is a lot more about the hormone replacement therapy and the bioidentical hormone use. I think it's a great question. I think for us in the medical community, I think that's a great question, but I feel like it's probably a little bit more complicated than what I can actually talk in the next few minutes. And I would say the good thing about hormone replacement therapy in general, whether it's the traditional or the bioidentical, is that the acceptance that there could be a role for this. And so before, we really weren't even, and I would say I don't prescribe HRT as a cardiologist or hormone replacement therapy. We weren't recommending this at all. And we do now know that it can be safe in the right patient population. But the individual variations of those hormones, I think it gets a little bit complicated. So great question. I think I'm going to pause on that only just because of the time and the focus on the therapies, I feel like is a little bit individually based. So
thank you. And are there any supplements that you recommend for menopausal women which help to lower their cardiovascular risk factors, such as vitamin D or omega-3?
Right now, there is really no role. Let me go back up to vitamin D, unless you're vitamin D deficient. I don't tend to check vitamin D levels because I work with amazing primary care physicians. But right now, the recommendations for vitamin D is only if you're deficient in it, and has not been linked to cardiovascular benefits. There is, and I won't get into it, but there is a big discussion of calcium supplementation and the deposition or depositing of calcium in those heart arteries. I'll just tell you that it's there. And I do talk to my patients about that. Omega-3, that's a great, omega-3 tend to be found in fish like salmon, I always tell my patients, as much as you can, get the things that you need from diet. We absorb foods definitely much better than supplements. Now, if you need a supplement, that's a different story. And I would say, going back to what I said, the calcium supplementation, when we increase the calcium in our food sources, we don't seem to see that rapid levels of calcium that we do when we take pills. And so as much as I can, if I have a patient who's, we're talking about minor cholesterol numbers in the wrong direction, we talk about diet, exercise. Do they need to lose weight? What is their intake of saturated fat? How can we introduce unsaturated fat through natural fish oils that we find in fish? I would say, though, this is such a great question, I want to make time for other folks because these are all great questions. There is a prescription form of omega-3 fatty acids called Vasepa, and I don't work for that pharmaceutical company. It's a medication that can be prescribed that can reduce LDL and total cholesterol because it's more concentrated than what we get at the local stores. But again, I just want to drive home that as much as you can get from food sources and natural lifestyle modifications is always my go-to when I can. So I hope that answered your question.
Yes, thank you.
And
there's a question whether you're finding, and what your thoughts are, that PCPs are discussing heart risk and menopause with women earlier in their life.
Yes, I think it's talks like this that are not educating the community to also bring up this topic. I'm very biased because, again, I'm in the Women's Heart Health Program here at MGH, and the reason for these visits is very much for those sex-specific differences, with menopause being a very important conversation, and a lot of the reason why they're coming to see me. I have to say, overall, yes, and it's not only from the patient bringing it up, for us as providers talking about this more. I can tell you, it hurts my heart how long that the stress of pregnancy and menopause, as I started out with, has been overlooked. In menopause, women were labeled and felt like some of their symptoms were not real, and we don't want to dig too into that, but the reality is that these were ignored. And I would say now we're not where we should be, but we are so much better. And so we are now aware of the transitions and the changes that are happening in these all across a woman's lifespan, but in particularly these two areas, and why it's so important. One, we need to learn more about it. And how do we get the message out that this is really important, that we identify these transition periods and the risks associated with them, and what we can do? Because at the end of the day, we have to reduce maternal health, and we have to reduce maternal mortality, so women dying during their pregnant. And overall, we have to continue to reduce mortality for women, because again, I will never ignore the risk of cancers, but heart disease is the #1 cause of women dying not only early but suddenly, and so we can have a huge impact here. So I really do think we're getting better. Are we there where we should be? Absolutely not. Which is one of my missions, is to make an impact in that. And where we're discussing these things. If you recall the first slide I showed, or second, third, a lot of women didn't bring this up because they felt like they were going to be shamed because everything was linked to obesity, which it is not. And even if you are obese, we should never have that environment where people don't feel comfortable talking about that. And I do think the medical society is more in tune with the importance of that patient-physician relationship and that open communication, and what we really call patient-shared decision-making, where the patient is an active part of what we do and how we move forward. So, and And I would just say finally, as an educator, as associate program director for my fellows, and also for, that's another great question, and being clerkship director for one of the Harvard medical students rotations, we as educators are really instilling the power of conversation, bedside manner with our patients, and opening up those barriers to difficult conversations. So I would say we make an impact from the education level also.
Thank you so much. I see that we are at time, but I don't know if you have a minute to spare to get your thoughts on keto versus plant-based diet. Which one's better for a premenopausal woman?
Well, I don't know if there's data. A diet's really hard to study, I'm going to tell you, because you're basically you're relying on somebody's recall. And I would say, do people always record in a research study what they're actually eating? So what I'm saying is that if you look at the well-designed studies on diet, there are not that many of them. It's really, really, really hard. I would say in general, I'm a big proponent of the Mediterranean diet. It's the American Heart Association and data that we have. This will really reduce cardiovascular risk. And you can go on the American Heart Association and look up the little pyramid where they talk about limiting these and having more of these. That is the one that's the tried and true. These other diets come and go. And they're not always necessarily bad, but the one that has shown consistency to improve heart health is the Mediterranean diet. I always try to find ways of increasing protein through plant-based options with my patients as much as I can. There's other great sources of protein like lean chicken, lean meat if you need that, but really reducing red meat and saturated fat. So I would say Mediterranean plant-based would be my go-to. Again, the Mediterranean diet has been around for a long time. Consistency means a lot to me. As a cardiologist, I don't jump on things that come out right away. They have to show not only medication but interventions shown consistency in the literature that they make an impact. And that's why the Mediterranean diet will always get my my support, because it has been shown in very well-designed studies that it can improve heart health. So I hope that answered your question. Also know that there's always some individual variation in conversations that you can have with your medical team.
Yes, it does. Thank you so much. All right, so I think that's all the time that we have for today. Thank you so much, Dr. Harrington, for spending the hour with us.
Thank you.
And for everyone who's spent the time to join our program, thank you so much. Hopefully you found it helpful. As I had mentioned, today's program is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone.
Thanks again. Thanks for joining.
Take care.
Bye-bye.